Let's study about nephrotic syndrome. The characteristic features of nephrotic syndromes are massive proteinuria, hypoalbuminemia, edema, hyperlipidemia can be associated. Some patients have hematuria and hypertension. Due to increased permeability of glomerular basement membrane, there is heavy proteinuria. Proteinuria means protein excreting more than 1 gram per meter square per day. This will result into hypoalbuminemia. That means serum albumin level will become below 2.5 gram per deciliter. Due to hypoalbuminemia, there will be decrease in plasma oncotic pressure, which will result it into interstitial edema and hypovolemia. Due to this, there is a stimulation of RAS system and ADH, and there is sodium and water retention, which will result in edema. Due to hypoalbuminemia also induce hepatic synthesis of beta lipoproteins, which will result in hypercholesterolemia. In some patients, there is significant glomerular lesions which will have primary sodium retention and expanded intravascular volume. The causes of nephrotic syndrome are idiopathic in majority of cases. There can be other causes like amyloidosis, vasculitis, SLE, post-infectious glomerulonephritis, and hepatitis B nephropathy. Nephrotic syndrome can be divided into two: minimal change nephrotic syndrome and nephrotic syndrome with significant lesions. The difference between both is minimal lesions. Minimal lesions is present. The age of onset is 2 to 6 years, and of significant lesion is in older children. Sex incidence higher in boys and equal in significant. Hematuria is rare and minimal and usual insignificant. Blood pressure is normal, increase in significant lesions. GFR is normal, decreased in significant lesions. Renal biopsy usually not performed. If performed, then IgM deposits are seen and normal glomeruli with mild mesangial proliferation. If renal biopsy is done, then changes of varying severity is seen. C3 immunoglobulin deposits, C3 and immunoglobulin deposits are also seen. Serum C3 is normal in minimal and low in significant. Selectivity of proteinuria, there is high proteinuria in minimal and low in significant. Response to steroids, minimal lesions beautifully respond to steroids, while significant lesions doesn't respond to steroids. Prognosis is good as they are responding to steroids, and their progression, and significant lesions as they are not responding to steroids, they may lead to renal damage. So minimal change nephrotic syndrome is steroid sensitive nephrotic syndrome. When we will do renal biopsy in light microscopy, it doesn't show significant abnormalities. In electron microscopy, we can see non-specific obliteration of epithelial foot process, and in immunofluorescence we can see mesangial IgM, and they are also seen occasionally. In focal segmental glomerulosclerosis, that is steroid resistant, there is sclerosis of a segment of glomerular tuft. What is the pathogenesis of minimal change nephrotic syndrome? Due to perturbation of cell-mediated immunity, there is alteration in perm selectivity of glomerular filter. This will result in proteinuria. What is the clinical features? Onset is insidious. There is edema. First it is in eyes and legs, and then it spread and become generalized. Generalized form is ascites, hydrothorax and hydrocele. Edema is usually soft and pits easily on pressure, that is pitting edema. If the edema is increasing by time, then the urine output will decrease and may lead into oliguria. Usually BP is normal. It is increased in significant glomerular lesions. After loss of edema, we can see the muscular wasting, wasting. Infections may be present at the onset and during relapses. What are the laboratory findings? That there is heavy proteinuria, there is hyaline and granular cast. Serum albumin is less than 1 gram per deciliter. Hypercholesterolemia will make the plasma milky appearance. Blood urea and creatinine is in normal range. Blood levels of IgG are low and IgM are elevated. C3 levels are normal. Severity of glomerular damage. Passage of large molecular weight proteins, that is globulin, will represent there is severe glomerular damage. Evaluation at onset of nephrotic syndrome if there is proteinuria, blood levels of urea, creatinine, albumin, and cholesterol, complete blood count, tuberculin test. We can also perform C3 and anti-streptolysin O if there is persistent microscopic hematuria. We can do chest X-ray if the tuberculin test is positive and or the patient is contact with tuberculosis. We can do hepatitis B surface antigen test if there is recent jaundice or there is increased level of transaminase. We can do anti-nuclear antibody to rule out SLE. We can do urine culture if there is a suspect of UTI. Renal biopsy if there is nephrotic range proteinuria despite of appropriate steroid therapy. What is the management of initial episode? We will give high protein diet. We shouldn't give extra salt. Infection treated if present. Screening for TB. Diuretics if significant edema, and diuretics are used cautiously and overzealous fluid loss is avoided. In diuretics we give furosemide at the dose 1 to 4 mg per kg per day in 2 divided dose, and if it is severe we can add aldosterone antagonist like spironolactone. We can give corticosteroids like prednisolone or prednisone, and the dose is 60 mg per meter square per day maximum, and this dose is given for 6 weeks, and after that we give 40 mg per meter square for next 6 weeks, and then the therapy is stopped. If corticosteroids are given for more than 12 weeks, then there is increased risk of toxicity, so that's why we do not use corticosteroids for more than 12 weeks. We can give parent education about the disease and outcome of this disease and their cooperation to be ensured. What is the subsequent course? The nephrotic syndrome can have remission. Remission is noted if the urine albumin is nil or there is trace for 3 consecutive early morning specimens. Relapse if urine albumin is 3 plus or 4 plus in 3 consecutive early morning specimens. Frequent relapse if there is 2 or more relapse in initial 6 months or 4 or more relapse in any 12 months. Steroid dependence, that 2 consecutive relapses when on alternate day steroids within 14 days of its discontinuation. Steroid dependence when there is a relapse after 14 days of its discontinuation. Steroid resistance if there is absence of remission despite therapy for 4 weeks. What is the management of relapse? Commonly, relapse are triggered by minor infection, so we will give symptomatic treatment, and usually there is remission of low-grade proteinuria, but there is persistence of high-grade proteinuria, so we will give prednisolone 60 mg per meter square per day for 3 consecutive days, and then we will give 40 mg per meter square for for 4 weeks at alternate days. Frequent relapse and steroid dependence. We will use long term alternate for the cases which are frequently relapsing and there is a steroid dependence. We will give long term alternate day prednisolone, that is given for 9 to 18 months. And if repeated relapse present, then we will give steroid sparing agents. Steroid sparing agents are given if prednisolone threshold is more than 0.5 to 0.7 mg per kg at alternate days, or features of corticosteroid toxicity. Steroid sparing agents are levamisole, that is immunomodulator, given at a dose 2 to 2.5 mg per kg for 1 to 2 years. The side effects are leukopenia, flu-like symptoms and rash. We can give cyclophosphamide, that is 12-week course, and dose is 2 to 2.5 mg per kg per day, and side effect is leukopenia, nausea, vomiting. We can give mycophenolate mofetil. The dose is 60 to 100 mg per meter square and given for longer duration, 1 to 3 years. We can give cyclosporin and tacrolimus, that are also given for a longer duration, and the dose is 4 to 5 mg per kg and 0.1 to 0.2 mg for tacrolimus. And we can give rituximab at a dose 375 mg per meter square IV, and the doses given are 1 to 2 doses. And the side effects are infusion reaction like fever, rash and bronchospasm and neutropenia. What are the complications of nephrotic syndrome? The edema, salt restriction. For treatment, we can do salt restriction and oral hydrochlorothiazide, or we can give furosemide, or if it is severe, then we can give spironolactone along with it. We can give infusion of albumin if there is oliguria or poor renal perfusion. For infections, mainly the infections are caused by strep pneumoniae, gram-negative and varicella, gram-negative organisms and varicella. In peritonitis, the features are low-grade fever, diarrhea and abdominal discomfort. Varicella, if there is varicella present, then we will give oral acyclovir for 7 days, and if it is severe, then we will give intravenous acyclovir. Immunization with pneumococcal and varicella vaccine after the treatment. Thrombotic complications. This will involve renal, pulmonary and cerebral veins, and the treatment is low molecular weight heparin, and then it is followed by oral anticoagulants. Hypovolemia and acute renal failure. The features are abdominal pain, lethargy, dizziness, leg cramps, tachycardia, hypertension, low volume pulses, clammy distal extremities. And the therapy is steroid for hypovolemia and acute renal failure. For steroid toxicity, the features are Cushingoid features and short stature. The treatment is steroid sparing agents. Other features of steroid toxicity: hypertension, osteoporosis and subcapsular cataract. Let's study about steroid resistant nephrotic syndrome, that is significant lesions present. Diagnosis is if there is lack of remission despite of treatment for 4 weeks. Renal biopsy is done before giving treatment. Cause: in 20 to 30% cases, there is heterozygous mutation of NPHS2, NPHS1 and Wilms tumor 1 gene. We will do screening by next-gen sequencing using targeted gene. Management is decreased proteinuria. We will give prednisolone, ACE inhibitors and angiotensin receptor inhibitors if there is dry cough after ACE inhibitors. Therapy of steroid sensitive nephrotic syndrome: prednisolone, levamisole, cyclophosphamide, mycophenolate mofetil, cyclosporin, tacrolimus and rituximab. Basically, we will use the steroid sparing agents. If there is persistent hypercholesterolemia, then we will give HMG coenzyme A. We will do hypertension control, infection management, edema minimized, and we will give IV albumin if there is oliguria and decreased renal perfusion.